Hello, all. Welcome back to the second day of APAC India Digital Empowerment Meet and Awards. Second day is completely dedicated to healthcare, and we are still in the inaugural session. In the beginning, we had seen the presence of Honorable Healthcare Minister of Chhattisgarh, Sri T.S. Singh Deo, and Secretary of Health Puducherry, Dr. T. Arun, and CEO and Director of AIMS Bhatinda and AIMS Bhopal. And then it was followed by a panel discussion on hospital administrators' perspective on building digital infrastructure for a better and connected healthcare system. Dr. K. Hari Prasad from Apollo Hospitals, Dr. Alok Roy from Medica Super Specialty Hospitals, and Abrar Ali Dalal from Sahyadri Hospitals were part of that panel discussion. And now we have got a special guest. We have with us Dr. Pankaj Gupta, Head of Department Digital Health, Access Health Digital. He'll be giving a special address on India's digital health journey and road ahead. We welcome Dr. Pankaj Gupta. Thank you so much for joining us today.
Thanks a lot for having me. It is a pleasure to meet all the people here, and we are living in a new normal. It's completely a virtual world, and so digital has taken off in a very big way in this new normal. Let me try to share my screen. Let me see if I can bring up my slide deck,
Sure.
and then we'll be able to take it forward. I hope my screen is visible.
Yeah, you can put it in. Yeah, it's perfect there. Yeah.
Perfect. Thank you so much. So today I'm going to be talking about India's digital health journey and the road ahead. And this is a topic that is very close to my heart because for the last couple of years, almost a decade now, I have been very closely associated with the digital health transformation that is underway. And I've been working closely with the government of India in various capacities to sort of see that the digital health transformation happens. So let me walk you through a little bit in terms of how this has gone over the last couple of years. So the digital health transformation actually started way back in 2005 when the Generation 1 IT systems came in. The National Rural Health Mission put IT systems in the vertical programs and the district hospitals that were called HMIS systems and things like that. But all these systems were in silos because it was never designed to sort of capture all the data, and it was never designed for interoperability. So if there was a low birth weight baby born to a woman who had tuberculosis in the past, there was no way you could trace that the low birth weight is probably because of the tuberculosis in the past, because all the was in separate systems. Because you have the pregnancy data in one system, the birth data in one system, you have all the other components for tuberculosis in another system, and so on and so forth. So although this was a great start, but it was never designed for interoperability. Different systems built at different points in time, different technologies, and almost no standards. That is the reason in 2013-14 there was two committees that were created, the EHR committee and the MDDS for Health committee, and to write the detailed standards in terms of what should be. And I had the privilege of leading the MDDS for Health committee, and we completed our work in 2013. It was put in public domain in 2014. It took about 5 years of consultations and reconsultations and back and forth. So MDDS for Health got notified in 2018. Though EHR standards got notified in 2013 and then revised in 2016. Similarly, there were other efforts on the health facility registry. A lot of work happened on the NIN. That was a very early step to get a healthcare facility registry together. And then after that, there was an NHRR and other thing. Now, Government of India is reviving that effort, trying to bring all the data together from what has been done. So all of this effort culminated in 2018, where Ayushman Bharat was announced. Ayushman Bharat needs a digital backbone to make it happen. So that was announced in somewhere in the second part of 2018, and then the graph took off from there in a major way. So you have the National Digital Health Blueprint, and then the National Digital Health Mission being announced, and now the latest one is the Unified Health Interface being announced by the Government of India. So this is a journey that we have been very closely associated from Access Health Digital, and we've been working to make sure that it happens very seamlessly. So, National Digital Health Blueprint is already there. It's a beautiful book which tells you all the standards. I talked about the metadata standards for health. So that's also a beautiful book sitting there. But then, to make use of all of this across the universal health coverage, the e-governance, and epidemiology, you need building blocks. And these building blocks are the e-objects, the MVPs, privacy and security, and so on and so forth. So they have to be open source, and they have to be built on the standards, the National Digital Health Blueprint and the metadata standards. Only then you'll get the data quality to be able to service the universal health coverage, the e-governance, and epidemiology. We see that these are the three major levers for the digital health transformation to happen. But for that to happen, we need all these standards to be in place. What happens if you don't have the building blocks? If you don't have the building blocks, then the standards are still there, but then you're not able to get the data quality that is required to service the levers, and the transformation will not happen. So let's look at the major areas of transformation as the levers of transformation. The universal health coverage, why do we say is a lever? Because PMJ is set to cover about 40% of India's population. Health insurance consolidation will happen, which is underway, and it will cross the 53% of the population. And then claims are set to go up by at least 10 times. So insurance will start asking for claims in a standard NDHP format. Insurance has no choice, because health insurance will have to go completely digital to manage the tsunami of claims which is coming. So this is a change that is a huge change for the Indian healthcare system that is definitely going to happen in the next couple of years. So how does it affect the entire healthcare ecosystem? It affects because your money depends on it. So if your money depends on it, the providers will have to give the claim in a standard format, the EClaim format as it's being called. So these are the e-objects that we designed, and we've been working very closely with the government to sort of put it in place. The first time the concept of e-objects was published in a book called Health System for New India, which was published by Niti Aayog. And the chapter 5 is a digital health chapter. I'm a co-author of that. And we sort of put out the e-claim object, all the provider objects, e-bill, e-discharge summary, e-encounter, all these objects. So what are these objects? These are basically minimum data set that is required for any transaction. So if a patient is getting discharged from a hospital, what is the minimum data set that is required for e-discharge? If the claim has to be sent out, what is the minimum data set that a claim should have, right? So these are the kind of things that are built into the objects. So similarly, the e-bill. So, if you have to create an e-bill, then what is the minimum data element that are required? So there is an opportunity for the market on creating these e-objects, and then there is an opportunity on the adjudication side, on the payer side, to adjudicate it. There's an auto adjudication model where humans need not do it. So once the money depends on it, then the providers are willing to spend time, effort, and making the interoperability happen. So these are all machine readable objects that are going to come in place. Moving to the second lever, which is epidemiological lever. So right now we are in the midst of the pandemic, and we are failing in the pandemic in many ways. We had a very massive second wave, and we are staring at the third wave coming. So the data which is being analyzed, which is being brought together from the different parts of healthcare, so which is basically, the hospital information systems, the clinics, EMRs, labs, radiology, home care, telemedicine, all of that put together is something that is not going to be possible if you don't have the standardized interfaces in place. So those are the standardized interfaces that we really require, so that you can bring all of this together and analyze the patient data, so that the clinical experience get enriched, and then the published papers are put in place. Only then you can identify the hotspots, containment zones, and do resource optimization. Now, this is a very important aspect, because you're not getting the data in standardized format. You are having to do a lot of data scrubbing to bring all of it in a standardized format to analyze it from an epidemiological perspective. If you were getting the data seamlessly, it will happen near real time. So, there's no human intervention required. You're getting the data from all the labs, from all the hospitals, and it's in a standardized format. It gets into a large database. You are able to do epidemiological analysis. So the change is inevitable. We are approaching a time when, because of the standards, this will happen, and pandemic is accelerating the adoption of the standards. Similarly, e-governance. So, the foundation of resource optimization. So we found that, lots of hospitals, lots of state governments were finding it very difficult to, on the supply chain side of drugs, oxygen, consumables, and many other things. So this is happening because the registries are not in place. We don't have a doctor's registry. We don't have a health facility registry. So if you don't have the registries as a single source of truth, then you can't do supply chain optimization. You can't do resource optimization. And that is a very important thing to deliver any governance model. And thankfully, government has taken it up now, and the work is going on to put the registries together. So these are unique identifiers for the doctors, unique identifier for the healthcare facilities, and so on and so forth. Let's look at the open source building blocks that I talked about, without which things are not going to be possible. E-objects for interoperability. What are these e-objects? So, e-objects are basically transactions and code sets. So for transaction, you have a standard format for the transaction, and then you have code sets. So for example, you codify the diagnosis using ICD-10, procedures and order sets, for all your clinical terminology is SNOMED, and then labs are so the standard you use for the laboratories is LOINC, and NFI is for the drug index. So these are the standard code sets, and for the transactions, what you do is you define a minimum data set. So here we have the e-objects listed for the payer side and the provider side. The provider side e-objects are, e-encounter, e-prescription, e-referral, and e-discharge. Well, they are self-explanatory, but just to help you understand, when a patient is getting discharged from a hospital, you get an e-discharge, which is basically a minimum set of data elements that are required to convey all the details in a discharge summary. And if there is a telemedicine consult, at the end of a telemedicine consult, two things should come out, e-prescription and an e-referral. So if there is an e-prescription that comes out, the drugs are in a machine readable format, it can be sent to e-pharmacy or a normal pharmacy that can sort of have a software to read the machine readable e-prescription and then process it. And e-referral, so that the referral can be done to a higher center if required, from primary to secondary, secondary to tertiary. And then similarly, from tertiary to the payer, if you have to send, then it's an EClaim that is there on the left-hand side as we put it. So a lot of work is going on this in the government, and things will be rolled out in the private sector as it matures. The adoption will obviously take a little while, but the work is going on. The other building block is microservices. Now, what are microservices? You all watch OTT platforms like Amazon and Netflix and all that. So these are the platforms which are run on a technology called microservices. This is a next generation technology where the monolithic model, which is the client server monolithic model of the past, has given way, and the microservices have come in. So the advantage of microservices is that every functionality will sort of be broken down into one microservice, or one microservice will service one functionality, and bundle of microservices will form a module, and each microservice will have a database of its own, and you can build an application. Now, have you ever seen an Ola application, or the app that you have, or a Uber app that you have, or a Netflix app that you have going down? So the entire app never goes down, even if you have to if the service provider has to update or upgrade the services, they will bring down only one microservice. They don't have to bring down the entire system. So the system remains up forever. And also the cost of hosting, cost of running comes down significantly, because this is amenable to software as a service model. You have to put it on the cloud and you're good to go. And even a serverless technology is something that is possible, and then microservices render towards serverless technology pretty well. We have put the design for the minimum viable product microservices in the open source. So what we've done is we designed all the microservices and put it out there. We said whoever wants to build a new healthcare application, they can sort of pick up these microservices, bundle it together, and you'll have to build a user interface on top, and you're good to go. So we are an NGO. We are helping the market adopt the standards, and for that effort, we put all of this into open source. Hopefully, the adoption will happen. The next one is data privacy. Now, that's a very hotly debated topic, and it's very contextual in nature, because what is private for one may not be private for another, and it is also very culturally sensitive. So, what is private for the Western part of the world may not be that private for India, and vice versa. So you have to contextualize it, and a lot of work is going on data privacy. Some of the regulations have been put in place, but then it is waiting for a larger debate to happen in the parliament. And we should see a Data Privacy Act coming over a period of time. But more bigger concern is from data security. So we should focus more on security than privacy, because majority of the breaches that happen are because of data security. So you need to have network security, you need to have data security, and you have to have physical security as per the standards which are sort of laid down in the National Digital Health Blueprint, and to make sure that the data is not breached. Because when you are running very, very large systems, there is a very good chance that data breach will happen. And it may not be from within the country, it may happen from outside, because of the attacks that happen, the cyber attacks that happen. And you have to be prepared for it. The last but not the least is identifiers. So you need all the registries, as I mentioned, as a single source of truth. You need the beneficiary registry, the doctor's registry, the health facility registry, and then you need the document registry. You need to know we are heading towards a federated model where not all the data will be stored in a central server. The data will remain with the respective facilities, and it will be called out on demand. And for that, you need a document registry in which you need to know which data or which document is in which system, and then you can pull it on demand. And obviously, all the rules will have to be built in. So the infrastructure is being designed as of now, and the work is going on. What we are heading towards is a level playing field. So earlier you had a very old world where A lot of custom built applications were there. There were proprietary applications also, but open source was really small. Now we are heading towards a level playing field. What happened in telecom and banking many years ago is now happening to healthcare. And now the world is different. We have digital technology. The client server monolith technology is gone. So in a level playing field, what will happen is you will have all the proprietary open source cutting edge cutting edge technology and custom build sort of simultaneously existing and competing for the same market in an open bazaar kind of a model. So a bazaar model is definitely emerging. As you know that it has already happened in retail and telecom and a couple of other industries. So we are going to see the same thing happen to healthcare. Software as a service, platform as a service model is emerging. We are working very closely with some of the service providers to bring healthcare software as a service and platform as a service. So we run a social entrepreneurship accelerator where there are about 40 healthcare startups working with us to sort of adopt all the building blocks that I talked about. And also very soon, they will be on the SaaS platform. So I will end my talk with that. Here are my contact details. Thank you so much for listening to me. It has been a pleasure interacting with all of you.
Thank you so much, Dr. Pankaj Gupta, Head of Department Digital Health, Access Health Digital, for your special presentation and address on India's digital health journey and road ahead. I must say it has been a comprehensive presentation where you talked about the entire journey of last decade or so and what the future lies. You talked about starting days of NRHM in 2008 to 2021, in between Ayushman Bharat, then National Digital Health Mission, Unified Access Healthcare. Also, you talked about why we have failed in the second wave during the pandemic because we are not having that model of machine readable healthcare and medtech data standards population. You talked about e-object. You talked about more focus should be given to data security rather than data privacy. And as you have talked about the software service, that is the future, and how this lot of startups and entrepreneurs are coming together, and how Access Health Digital is trying to make a difference in that sphere. Thank you so much, Dr. Pankaj Gupta, for joining us in the inaugural of 3-day APAC Digital Empowerment Meet and Awards 2021. This day is completely dedicated to healthcare. Yesterday it was on governance, and tomorrow it will be on education. Thank you for joining us. For our viewers, for our audience, please come back at 1:15 p.m. today for a panel discussion on leveraging newest technologies to strengthen health system to improve outcomes. And before I let Dr. Pankaj Gupta go, we have a small token of appreciation for you. This certificate is proudly presented to Dr. Pankaj Gupta, Head of the Department Digital Health, Access Health Digital, for his dedicated efforts and exemplary work in healthcare. Thank you so much for joining us today.
Thank you so much.
Do join us for next session at 1:15 p.m. Thank you so
Thank you.
much.
Thank you.